Welcome.
Thank you, Mr. Chairman. Thank you for the opportunity to be here. This is a study performed by the Special Interest Group of the Italian Association for the Study of the Liver, focused on ACC and new anti-ACV therapies. This group includes a multidisciplinary team with hepatologists, radiologists, and hepatobiliary surgeons. The first aspect of this group is to study the ACC occurrence rate after DAA. As you know, there is a great evidence about this, and now we can say that there is a decreased occurrence of ACC after DAA. A second problem we are studying is the problem of ACC recurrence in patients with a previous history of ACC. And the evidence here is more heterogeneous and the data are less strong, but we can answer that there is not a great evidence of an increased recurrence rate in patients undergoing DAA. But the third aspect, the fourth most important aspect, is what about the effect of DAA on tumor aggressiveness? As you know, the gold standard to evaluate this effect should be to study pathological examination. So the ideal group to study is the group of patients undergoing surgery. In Italy, fortunately, we have a liberal policy for ACC resection, so we have not a problem of selection bias in patients undergoing surgery, because we included in surgery also patients in the intermediate and the advanced stages of the disease. So we enrolled 420 consecutive patients undergoing liver resection for ACC on ACV cirrhosis during 3 years period, the initial period of DAA prescription in Italy. We included 18 Italian hepatobiliary surgical units. And we enrolled 78 patients, 90% of patients, who had DAA therapy before surgery. This group represented the study group, while the remaining 342 patients formed the control group. The primary endpoint of the study is to evaluate the pathological characteristics, because the pathological characteristics explain to us the biological aggressiveness of the tumor. The secondary endpoint is to evaluate the early postoperative outcome. We use inverse probability of treatment weighting to balance the preoperative characteristics of the two groups for the evaluation of the primary and secondary endpoints. These are the study groups. As you can see, we have some differences in the groups in terms of age, diabetes. In particular, the study group had a more compromised liver function in terms of MELD score and the portal hypertension. But the radiological tumor diameter was significantly lower in the study group, with a lower proportion of macroscopic vascular invasion and a lower proportion of patients undergoing major resection. After weighting, as you can see, we had similar characteristics, preoperative characteristics between the two groups. And interestingly, we have a larger sample size, a pseudo population in the study group. This is important to have a good comparison between groups. In the unweighted population, this is the primary endpoint, we did not find significant differences in terms of pathological characteristics. The only differences were a lower largest diameter in the study group, and another interesting finding is that aggressive pathology defined by poorly differentiated ACC or vascular invasion or satellitosis was significantly lower in the study group. This is an unexpected result. But After weighting, only the diameter remained significantly lower, while the two groups were comparable in terms of aggressive pathology incidence in the pathological examination. This is a graphical representation. As you can see, there was a trend in a less proportion of aggressive pathology in the study group, but this proportion became similar to the control group after weighting. We analyzed the predictors of aggressive pathology. The predictors in the whole group were largest diameter and alpha-fetoprotein. In the study group, only alpha-fetoprotein preoperatively predicts an aggressive pathology at a pathological examination. The secondary endpoint was early postoperative outcome. In the unweighted population, you can see that the study population has a lower incidence of severe complication. So the clinically relevant morbidity after resection was significantly lower in the study group, only 2.6%. There was also a trend for a lower mortality, early mortality. After weighting, also mortality became significantly lower in the study group because this is a problem of sample size. We have only 2% in the study group versus 5.4% in the control group. We analyzed the predictors of early mortality. In the unweighted population, you can see that DA therapy has no effect on early mortality, but were important MELD score, diameter, and previous resection. But after weighting, DA became protective in reducing the risk of death, of early death after liver resection, independently from liver function, technique, and tumor characteristics. The follow-up of this study is very short, so this is not very informative, but we performed also a competitive risk analysis where the competitive risk were death due to cancer and death due to other causes, but we did not find a significant difference between the study groups. So in conclusions, DA therapy doesn't seem to modify the biological aggressiveness of recurrent or naive ACC undergoing liver resection. Conversely, the preoperative ACV clearance seems to improve the early postoperative outcome of these patients. This benefit may be potentially expected also after local regional therapies for ACC. In conclusion, I thank all the participants to this group, but in particular, I want to thank the directors of the hepatobiliary surgery because this study is possible only for their data. Thank you very much for your attention.
Any questions from audio? Okay.
Michał Grant, Warsaw, Poland. I'd like to ask you about the changes of the pathological, maybe not pathological, but morphological characteristics of the HCC and alpha-fetoprotein concentration during the DAA treatment, because you showed us that there were no differences at the end of treatment, but we don't know, in my opinion, from your study, whether this characteristic did not change during the treatment, as you don't have the initial data. So, and the second question is about the selection bias, because you say that you have no selection bias associated with qualification for the liver resection itself, but what was the potential selection bias associated with qualification for selection of patients for the DAA? Thank you.
Thank you for your questions. The first question, unfortunately, we have no data about the therapy with DAA. But I think that is important, the last value of alpha-fetoprotein and the morphological characteristics, because, and we have this data before liver resection. So it's important the dynamics, but as in the liver transplantation field, for example, what is important is the last value of alpha-fetoprotein, but we have not this data. The second question is about selection bias. I make mistake. We have selection bias. The selection bias is reduced because we have liberal enrollment criteria for ACC resection, but the selection bias is intrinsic to this study because we have no patients undergoing chemoembolization or other therapies. But if you want to analyze pathological characteristics, this is the only way we can do this thing. Thank you.
Alessandro, Prashant from India. I think wonderful study. Congratulations, because in an age where everyone is worried about the effect of DAAs on the aggressiveness, I think it's an important study. But I hope you will not stop here, because ultimately the pathology is going to reflect in the recurrence rate of the HCC. And because if you want to say later on that probably if there is a very high hepatitis C viral load, you should treat the hepatitis C initially and maybe wait for a month or so before you actually do the resection for the tumor. You will have to show that further on, not only immediate post-operative, but also the recurrence outcomes are not different in between the DAA versus no DAA group.
I completely agree with you. For a complete assessment of this study, we need complete follow-up data. This is only a first result about pathology, but we need the follow-up.
Thank you. We have to proceed because we have the time. Thank you very much once more.